Welcome to our video on trisomy 21, 18, and 13. Before we get started, please know that most of the details you need to remember about these trisomies can be quickly memorized with image mnemonics, which is found in our genetics section. Trisomy 21 is also known as Down syndrome. Most cases of Down syndrome are due to meiotic non-disjunction, especially during meiosis I. Minor cases might also be due to unbalanced Robertsonian translocations, most commonly between chromosomes 14 and 21. Down syndrome patients with Robertsonian translocations have 46 chromosomes but 3 functional copies of chromosome 21. Down syndrome is the most common cause of genetic intellectual disability. As for the risk factors, advanced maternal age of greater than 35 years is the greatest risk factor. Being a carrier of a Robertsonian translocation is another risk factor for having a child with Down syndrome. All right, let's talk about signs and symptoms of Down syndrome. These patients commonly have intellectual disability. They also have characteristic facial features like flat facies, prominent epicanthal folds, and a single transverse palmar crease. Patients often have a curved fifth finger, also known as clinodactyly, and a sandal toe deformity, signifying an increased bilateral distance between the first and second toes. Finally, they also have brushfield spots, which are white spots on the iris. Don't confuse brushfield spots in Down syndrome with Lisch nodules in neurofibromatosis type 1. Recall that Lisch nodules are brownish hamartomas on the iris, while brushfield spots are white. Here's an image from our partnership with Amboss, which highlights many of the classic features of Down syndrome that we've been describing. Here we see a comparison of brushfield spots and Lisch nodules. Again, brushfield spots are white spots on the iris, which we can see, for example, right here, and this is characteristic for Down syndrome, while Lisch nodules are brownish hamartomas on the iris, which we can see right here, and these are characteristic for neurofibromatosis type 1. All right, now let's move on to the complications of Down syndrome. Duodenal atresia is an extremely high-yield complication. It results from failure of duodenal luminal recanalization in the embryonic period. An abdominal X-ray in duodenal atresia shows the characteristic double bubble sign, which shows a distended duodenal bulb and stomach just proximal to the atretic duodenal segment. Okay, moving on, let's talk about Hirschsprung disease. This is caused by a failure of neural crest cells to migrate to the distal colon during the embryonic period of development. Consequently, Auerbach and Meissner's plexuses do not develop in the sigmoid colon and the rectum, resulting in a collapsed aganglionic distal colon. An abdominal X-ray in Hirschsprung disease shows a narrow distal segment. A biopsy of the colon in Hirschsprung disease will show an aganglionic region in the distal segment, and on imaging, we should see a proximally dilated colon. Let's talk about the cardiac complications next. As we learned from the discussion about Hirschsprung disease, Down syndrome patients have a defect in neural crest cell migration. Neural crest cells normally form the endocardial cushion in the embryonic heart, which in turn contributes to both the interatrial and interventricular septum. This is why Down syndrome patients commonly have concomitant atrial and ventricular septal defects, collectively known as AV septal defects. Down syndrome patients also have an increased risk for acute myelogenous or acute lymphoblastic leukemia. And finally, they're at risk for early onset Alzheimer's disease. The gene for the amyloid precursor protein is located on chromosome 21. Since Down syndrome patients have 3 copies of chromosome 21, they have more amyloid precursor protein and therefore an earlier accumulation of beta amyloid in the brain. Here we can see a classic double bubble sign on an abdominal X-ray of a patient with duodenal atresia. The first bubble is a distended stomach, which we can see here, while the second bubble is a distended duodenal bulb, which we can see here. Here is an abdominal X-ray of Hirschsprung disease. Hopefully you can appreciate the transitional zone right here. Moving on, let's talk about trisomy 18 or Edwards syndrome. Most cases of Edwards syndrome, just like those of Down syndrome, are due to meiotic non-disjunction. Edwards syndrome is the second most common trisomy, resulting in live birth after Down syndrome. A risk factor for Edwards syndrome, and generally for all autosomal trisomies, advanced maternal age of greater than 35 years. All right, now let's move on to discuss the signs and symptoms of Edwards syndrome. These patients commonly have intellectual disability. They also have a characteristic prominent occiput and clenched fists with overlapping fingers. Both of these features are pathognomonic for Edwards syndrome, and either one of them is usually mentioned in the question stem. Edwards syndrome patients also have a convexity of their feet, a finding known as the rocker bottom feet. They also have a small jaw, which is referred to as micronanthia, and finally they have low-set ears, which is a non-specific finding in autosomal trisomies. Here's a nice image from our partnership with Amboss, which highlights many of the key features of Edwards syndrome. Now we'll discuss the complications of Edwards syndrome. Just as we discussed in Down syndrome, Edwards syndrome patients also have a congenital heart disease, such as atrial septal defects or ventricular septal defects. They may also have an omphalocele, which is a midline protrusion of the abdominal organs covered by a gray peritoneal sac. Omphalocele is caused by a failure of the embryonic midgut to return to the abdominal cavity after physiologic herniation. They may also have myelomeningocele, which is a type of neural tube defect characterized by a cystic protrusion at the lower back containing both CSF and the cauda equina nerve roots. Finally, death usually occurs by 1 year of age. Here we see a comparison between omphalocele and gastroschisis. On the left image, there's a mild abdominal protrusion containing intestinal loops, which is covered by a gray peritoneal sac. And this is the classic appearance of an omphalocele. And on the right image, there is an intestinal protrusion to the right of the umbilicus, which is not covered by a peritoneal sac. And this is what gastroschisis typically looks like. All right, let's try a question. A 38-year-old male is brought to the physician due to memory changes. Family members first noticed these changes 4 years ago. He commonly forgets his parents' names, and he's been lost in his neighborhood several times during the past year. He was diagnosed with Down syndrome in his childhood. What is the best explanation for his early onset memory changes? All right, this patient has Down syndrome with memory changes over the last 4 years. He commonly forgets his parents' names, and he's been lost in his neighborhood several times. This presentation is consistent with early onset Alzheimer's disease. The reason why Down syndrome patients usually have early onset Alzheimer's disease is that the gene for amyloid precursor protein is located on chromosome 21. And these patients have an extra copy of chromosome 21, so amyloid beta accumulates in the brain faster. The last trisomy that we'll discuss in this subsection is trisomy 13, or Patau syndrome. Most cases of Patau syndrome, just like those of Down and Edwards syndromes, are due to meiotic non-disjunction. Patau syndrome is the third most common trisomy resulting in live birth. And like the other trisomies, a risk factor for Patau syndrome is advanced maternal age of greater than 35 years. All right, let's talk about the signs and symptoms of Patau syndrome. Before we discuss each of them, it's worth mentioning that Patau syndrome is characterized by midline defects due to failure of fusion of the prechordal mesoderm. In other words, the midline symmetry is disturbed, resulting in findings like hypotelorism, that is, closely set eyes. These patients commonly have a severe intellectual disability. They also have microphthalmia, which refers to small eyes, and microcephaly, which refers to a small head. Other common findings include a cleft lip or palate, cutis aplasia, which is characterized by an absence of skin on a portion of the scalp, as well as polydactyly. Here we see an image of the scalp showing the absence of skin, and this is a classic appearance of cutis aplasia seen in Patau syndrome. Okay, now let's discuss some complications of Patau syndrome. Just as we discussed in Down and Edwards syndromes, Patau syndrome patients also have congenital heart diseases, such as ASDs or VSDs. They may also develop holoprosencephaly, which is failure of the telencephalon to divide into the left and right cerebral hemispheres. An MRI in holoprosencephaly usually shows a monoventricle instead of two lateral ventricles, as well as the fusion of the basal ganglia. Patau syndrome patients may also have polycystic kidney disease, and death usually occurs before 1 year of age. Here's an ultrasound image of holoprosencephaly, and hopefully you can appreciate a large monoventricle, which we can see right here. Okay, let's wrap up with a final question. A 2-month-old boy is brought to the physician for a well child visit. He was born at 38 weeks of gestation via vaginal delivery to a 36-year-old female. The physical exam shows closed fists with index and little fingers overlapping the other fingers, a large occipital protuberance, bilateral convexity of the feet, and a small jaw. What is the most likely genetic mechanism of this patient's condition? All right, this infant presents with closed fists with overlapping fingers, a large occipital protuberance, bilateral convexity of the feet, and a small jaw. His mother has an advanced age of greater than 35 years. And all of these clues are consistent with the diagnosis of Edwards syndrome. Edwards syndrome, just like any other trisomy, is most commonly caused by meiotic non-disjunction. So the answer to the question is meiotic non-disjunction. And that concludes this section.